If you are a woman and have uterine fibroids, your doctor may recommend robotic fibroid tumor removal, also known as robotic myomectomy. Your reproductive organs include your vagina, cervix, uterus, fallopian tubes, and ovaries. A uterine fibroid, also known as a leiomyoma, is a non-cancerous tumor in your uterus. It begins with an abnormal growth of cells in your uterine wall. Uterine fibroids grow in place and don't spread or metastasize to other parts of your body. The four main types of uterine fibroids are intramural, which grows inside the wall of your uterus, subserosal, which grows on the outer wall of your uterus, submucosal, which grows in the inner wall of your uterus, and pedunculated, which grows on a small stalk attached to the inner or outer wall of your uterus. The size and location of your uterine fibroids may cause symptoms such as heavy menstrual bleeding, irregular bleeding between periods, lower back pain, pain during sex, frequent urination, fullness and enlargement of the lower abdomen, and pregnancy complications. Before your procedure, an intravenous line, or IV, will be started. You will be given antibiotics through the IV to decrease your chance of infection. You will be given general anesthesia to put you to sleep and block pain during the procedure. A breathing tube will be inserted through your mouth and into your airway to help you breathe during the operation. Your surgeon will make a small incision in or just above your belly button and insert a tube called a port. Carbon dioxide gas will pass through this port into your abdomen. The gas will inflate your abdomen, giving your surgeon more room to see and move the surgical tools. After your abdomen is inflated, a high-definition camera will be inserted into this port. Your surgeon will make additional port incisions for robotic instruments as well as for instruments used by patient-side assistants. An assistant will insert all of the robotic tools through these ports. Unlike standard laparoscopic instruments, these tools can rotate 360 degrees and have more flexibility than the human wrist. Seated at a special console, your surgeon will operate the robotic arms and the camera with joystick-like controls and foot pedals. A computer will translate the exact movements of your surgeon's fingers into precise movements of the surgical tools. At the same time, a high-definition vision system will provide a magnified three-dimensional stereoscopic view of the surgical area. Your surgeon will locate your uterine fibroid and inject it with medication to reduce bleeding. Next, your surgeon will carefully cut around the edges of your fibroid and remove it. Your uterus will not be removed. The remaining edges of your uterus will be closed with sutures. At the end of your procedure, the tiny incisions will be closed with stitches, staples, surgical glue, or skin closure strips. After your procedure, your breathing tube will be removed, and you will be taken to the recovery area for monitoring. You'll be given pain medication as needed. You may be released from the hospital the same day or within 1 day after the procedure.
When there are two babies inside the womb, it is called twin pregnancy. Both the twins are located in different positions with reference to each other. In an abnormal position, as shown in this picture, the first twin lies in a horizontal position. Its head lies in one flank and buttocks lie in the other flank. This is a transverse lie. The second twin may be in any position. Each twin has its own separate. When there are two babies inside the womb, it is called twin pregnancy. Both the twins are located in different positions with reference to each other. In an abnormal position, as shown in this picture, the first twin lies with his buttocks facing downwards, that is, breech presentation. The second twin may be in any position. Each twin has its own separate sac and has its own placenta. In a twin pregnancy, an abnormal situation arises if both the twins share a single placenta. When there are two babies inside the womb, it is called twin pregnancy. Both the twins are located in different positions with reference to each other. In a normal position, as shown in this picture, the first twin lies with its head facing downwards, that is, cephalic presentation. The second twin may be in any position. Each twin has its own separate sac and has its own placenta.
A tubal ligation procedure is a permanent method of birth control, where the surgeon cuts or seals off the fallopian tubes in order to prevent pregnancy. A woman's reproductive system includes the vagina, the canal where sperm are deposited and babies emerge during delivery; uterus, the pear-shaped organ where a fertilized egg grows into a baby; fallopian tubes, two ducts that transport eggs from the ovaries to the uterus and where sperm usually fertilize eggs; and ovaries, two glands that produce and release eggs. During sexual intercourse, sperm from the male are introduced into the vagina. They travel through a channel called the cervix and into the uterus. The sperm then move into the fallopian tubes, where they can meet and fertilize eggs that have been released from the ovaries. Pregnancy begins with a fertilized egg. If you don't want to become pregnant, you may choose a birth control method from one of several categories: abstinence, contraception, or sterilization to permanently avoid pregnancy by having a medical procedure. Tubal ligation is one form of sterilization. Before the procedure begins, an intravenous line will be started, and you will be offered medication to help you relax. Local anesthesia will be applied to numb the area of the operation, and you will remain awake for its duration. In some cases, general or spinal anesthesia may be used instead. If you are having a laparoscopic tubal ligation, your doctor will begin by making a tiny incision near your belly button and another just above your pubic bone. Your doctor will then inject carbon dioxide, a harmless gas, through a tube inserted into the upper incision. The carbon dioxide inflates your abdominal cavity, allowing your doctor to clearly see and work around your internal organs. Next, your doctor will introduce a lighted instrument called a laparoscope through one of the incisions. The laparoscope projects images of the structures inside your abdomen onto a monitor. Through the other incision, your doctor will pass surgical instruments to grasp your fallopian tubes and close them off using the cutting and tying, blocking, or sealing technique. At the end of the procedure, your doctor will allow the carbon dioxide to escape and close the incisions with dissolving stitches. If you are having a mini laparotomy tubal ligation, your doctor will make a small incision just above your pubic bone. He or she will grasp the fallopian tubes with forceps and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches. This method is often used just after childbirth. If you're having a laparotomy, your doctor will make a 2 to 5 inch incision in your lower abdomen. He or she will locate the fallopian tubes and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches. Immediately afterward, you will be taken to the recovery area. If you have a laparoscopic tubal ligation, you will likely go home the same day. If you have a laparotomy or a mini laparotomy after childbirth, your hospital stay may be extended slightly.
This is an abnormal position of the baby inside the womb. The baby lies in a horizontal plane with the head located in one of the flanks. The buttocks and feet are in the other flank. The placenta is normally situated in the upper part of the uterus. If it lies in the lower part of the uterus, it is called placenta previa. The placenta may extend downwards and may completely or incompletely cover the mouth of the uterus. This is an abnormal position of the baby inside the womb. It lies in a vertical plane with the buttocks downwards in the lower part of the uterus. It is called as breech presentation. The placenta lies normally in the upper part of the uterus. The important function of placenta is to carry oxygen and nutrients from mother to fetus via umbilical cord.
Polycystic ovary syndrome, also called PCOS, is an imbalance of the female sex hormones. The ovaries are part of the female reproductive system, along with the fallopian tubes, uterus, and vagina. Your ovaries contain your lifetime supply of eggs. These eggs are immature and are stored in tiny, fluid-filled structures called follicles. Your pituitary gland, located at the base of the brain, produces hormones that direct the function of your ovaries. Each month, the pituitary gland secretes follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH, into the bloodstream. After these hormones reach the ovaries, several hundred immature eggs start to mature, expanding the size of the follicles. As the eggs mature, the follicles secrete estrogen, the main female sex hormone. Once the amount of estrogen in the blood reaches a certain level, the pituitary sends a surge of luteinizing hormone to the ovaries, causing the most mature follicle to open and release its egg in a process called ovulation. The free egg travels through the fallopian tube where it awaits fertilization. Eventually, the remaining immature follicles and eggs dissolve. If the egg is not fertilized, the egg and the lining of the uterus are shed during the next menstrual period. If you have polycystic ovary syndrome, your pituitary gland may release abnormally high amounts of luteinizing hormone into your bloodstream, disrupting your normal menstrual cycle. As a result, your follicles do not mature and ovulation does not occur, which can lead to infertility. Some of the immature follicles do not dissolve and remain as fluid-filled sacs or cysts. In addition, your doctor may find your blood has high levels of insulin, a hormone produced by the pancreas. Too much insulin, combined with high levels of luteinizing hormone, can lead to excess production of a male hormone called testosterone in your ovaries. Abnormally high levels of testosterone prevent ovulation, which can lead to infertility. High levels of testosterone also cause many of the physical features associated with polycystic ovary syndrome, such as acne and abnormal hair growth. Having polycystic ovary syndrome raises your risk for type 2 diabetes because of excess insulin and insulin resistance, heart disease, high blood pressure, cholesterol abnormalities in the blood, and endometrial cancer. Since there is no cure for polycystic ovary syndrome, your doctor may recommend one or more medications to treat your symptoms, such as hormonal birth control, which, while preventing pregnancy, also regulates your menstrual cycle and reduces testosterone production in your ovaries. Anti-androgen medications, which reduce abnormal hair growth and acne. Diabetes medications, such as metformin, which lowers your insulin levels and regulates your menstrual cycle. And fertility medications, which can stimulate ovulation so you can become pregnant. If you want to become pregnant and fertility medications have not succeeded in restoring ovulation, your doctor may recommend laparoscopic ovarian drilling. During the procedure, your surgeon will insert a small needle into the ovary and use an electric current to destroy small areas of ovarian tissue where testosterone is produced. Over time, testosterone production diminishes and ovulation may occur.
A Pap test is a test to screen for cervical cancer or other cervical diseases. Your cervix is the lower part of the uterus, at the top of your vagina. A Pap test is used to check your cervix for abnormal cells. Abnormal cells can sometimes turn into cervical cancer if they aren't treated. A Pap test can be part of a pelvic exam. First, your healthcare provider will place an instrument called a speculum into your vagina. The speculum will be opened so that your cervix can be seen. Next, your provider will use a scraper or brush to gently collect cells from your cervix. Your cells will be examined at a lab under a microscope to see if any of them are abnormal. It usually takes about 1 to 3 weeks to get your test results. If you have questions about this test or your test results, talk to your provider.
The reproductive cycle begins with ovulation, the release of a ripe egg or ovum from the ovary. Hundreds of thousands of follicles sit nestled inside the ovary. Each follicle is a sphere of cells with an immature egg at its center. The typical 28-day menstrual cycle begins on the first day of menstrual bleeding. During the first 7 days of the cycle, a few follicles start to grow. These maturing follicles secrete estrogen hormone into the bloodstream to prepare the lining of the uterus for pregnancy. Around day 7, all of the follicles stop growing and begin to degenerate, except for one. This dominant follicle continues to grow, nourishing the developing egg inside it. Around day 12, the follicle secretes a surge of estrogen into the bloodstream. When the estrogen reaches the hypothalamus and the pituitary gland in the brain, the anterior or front part of the pituitary gland floods the bloodstream with luteinizing hormone. Around day 14, luteinizing hormone causes the follicle to undergo a sudden growth spurt. Right before ovulation, the egg detaches from the inside of the follicle. The bulging follicle releases chemicals, signaling one of the 2 fallopian tubes to move in closer and envelop the follicle. The follicle swells until it bursts open, ejecting the ovum and fluid from the follicle into the abdominal cavity. In response, the fimbriae, tiny finger-like projections at the end of the fallopian tube, sweep across the ovulation site and pick up the ovum. Microscopic cilia on the fimbrial surface guide the ovum to the entrance of the fallopian tube. Muscular contractions along the wall of the fallopian tube gently propel the ovum toward the uterus. The ovum lives for 12 to 24 hours, the interval where fertilization can occur. If not fertilized, the ovum will disintegrate and be shed along with the uterine lining during menstruation, marking the end of one reproductive cycle and the beginning of another.
As the baby moves randomly inside the womb, the umbilical cord gets entangled around the neck of the baby and also around the different parts of the body. Presence of cord around the neck of baby is called nuchal cord. In absence of any labor pains, the nuchal cord has no effect on any heart activity of the baby and it continues to beat normally at the rate of 110 to 160 beats per minute. With onset of labor pain, the baby descends into the birth passage. As the attachment of umbilical cord to placenta is fixed, the umbilical cord gets stretched and the loop around the neck of the baby gets tightened when the baby descends into the birth passage. The umbilical cord contains 2 arteries and 1 veins which supply blood and oxygen to the baby. As cord gets stretched, the patency of these vessels is affected, so the blood supply and oxygen supply to babies gets suddenly hampered. In such a situation, the baby is under stress. The heart reacts to stress by first beating faster, a condition known as tachycardia. If this condition is neglected, there is prolonged stress leading to the lowering down of the heart activity than normal, a condition known as bradycardia. In such circumstances, the baby can be lost if timely intervention is not taken.
reproductive system is wonderfully complex, yet the signals it gives you can be quite simple, helping you identify the fertile and infertile times in your cycle. You may have noticed different types of discharge throughout your menstrual cycle. The sensation that this discharge produces at the vaginal opening, called the vulva, also changes. This is because your cervix produces different types of mucus in response to changing hormone levels. Your cycle begins with menstrual bleeding, when the lining of your uterus, called the endometrium, is shed. Following menstruation, your cervix becomes blocked by a thick plug of mucus that prevents sperm from entering the uterus. This means that you are infertile. Many women feel dry at the vulva during this time. Other women notice a pattern of discharge that feels and looks the same day after day. The number of days that you experience this unchanging pattern will determine the length of your cycle. In an average cycle, this pattern of infertility lasts for a few days. If your cycle is short, you may not experience any days of this infertile pattern. In a longer cycle, you will have more. Early in your cycle, the pituitary gland in your brain begins to secrete a hormone called follicle-stimulating hormone, or FSH. FSH stimulates the growth of a group of follicles in your ovaries. Each follicle contains an egg and a bundle of surrounding cells that secrete the hormone estrogen. Estrogen activates the cervix to produce the mucus essential for fertility. This is the start of the fertile phase. The fertile phase, shown here using a baby symbol, begins a few days before ovulation. One type of mucus produced by the cervix dissolves the plug, which means sperm can now enter the uterus. Another type of mucus filters out damaged sperm cells. Yet another type nourishes the sperm, so they can live for up to 5 days in your reproductive system. It forms channels which help the sperm travel through your reproductive system to meet and fertilize the egg. You become aware of your developing fertility by the changes in the mucus that you feel and see at the vulva. You will notice that you feel increasingly wet and then slippery, and you may see mucus that becomes thinner and clearer. The last day of the slippery feeling is called the peak of fertility. It is very close to the time of ovulation. As one follicle nears maturity, the pituitary gland is stimulated to release a surge of another hormone called luteinizing hormone, or LH. LH triggers ovulation, the release of the egg from its follicle. The egg is swept up into the fallopian tube, ready to begin its journey towards the uterus. If fertilization doesn't occur, the egg will die within a day of ovulation. But if the egg meets any sperm along the way, fertilization can take place. After ovulation, the empty follicle is transformed into the corpus luteum. The corpus luteum produces a hormone called progesterone. Progesterone prepares the endometrium in case there's a fertilized egg ready to implant. It also causes the mucus to thicken and the plug to begin forming in the cervix again. The day following the peak, you'll no longer feel wet or slippery at the vulva. By the end of 3 days after the peak, your fertility for this cycle is over. About 2 weeks after ovulation, a new cycle begins. We can now see how essential cervical mucus is for fertility. Once you're familiar with your patterns, you'll be able to identify your fertile and infertile times. This knowledge can help you to achieve or avoid pregnancy.
Diagnostic pelvic laparoscopy is used to examine the internal organs of the pelvis in an effort to identify a specific problem. You might be advised to undergo diagnostic pelvic laparoscopy if you have pelvic pain or a mass, an abnormal accumulation of fluid, or difficulty becoming pregnant. These may be caused by endometriosis, tubal pregnancy, an ovarian cyst or tumor, scarring from pelvic infections, or other conditions. Laparoscopic techniques require only tiny keyhole incisions or puncture wounds, and the recovery period is much shorter and more comfortable. When you arrive at the hospital for your procedure, an intravenous line will be started and you may be given a sedative to help you relax. Pelvic laparoscopy is done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be temporarily inserted through your mouth and into your throat to help you breathe during the operation. A catheter will also be placed in your bladder to drain your urine. An uncomplicated diagnostic laparoscopy may take as little as 30 to 60 minutes. Your surgeon will gain access to the interior of your pelvis by using a sharp instrument called a trocar to make a small half-inch opening or port just below your navel or umbilicus. Carbon dioxide gas will then be pumped through this umbilical port to puff up your abdomen so its contents can be viewed more easily. Next, your surgeon will insert the laparoscope through the umbilical port. Images from its camera are projected onto a video monitor in the operating room. Your surgeon will carefully examine your pelvic organs and tissues, looking for signs of disease that might explain your symptoms. He or she may create other ports through which instruments can be slipped. These additional instruments are used to move organs out of the way for better viewing, or to perform operative procedures such as removing scar tissue, taking biopsies, or draining abnormal fluid. When the laparoscope and other instruments are removed, a special gas valve is left in place briefly to allow all the carbon dioxide to escape from the abdomen. The keyhole incisions are closed with just a few sutures or staples and then covered with bandages. After your surgery, your breathing tube will be removed and you will be monitored in the recovery area. Your catheter will be removed shortly thereafter, and you will be given pain medication as needed. Your intravenous line will come out when you can drink liquids. Most patients are released within a few hours of the procedure.
The menstrual cycle of fertile women usually lasts about a month. During this time, and under the influence of the body's own natural hormones, a tiny sac within the ovary containing an egg grows to about the size of a grape. At a point midway in the cycle, this egg is released from the ovary and ovulation occurs. Ovulation is also regulated by hormones. The egg, which from this moment on is ready for fertilization, then passes into the uterine tubes to await the arrival of fertile sperm. Ovulation is a naturally occurring event, and the desire to have children is a similarly natural instinct. But that instinct cannot always be fulfilled. The causes of unwanted childlessness are numerous, but so are the means of treating them. With the technique of intrauterine insemination, sperm is provided either by the male partner or by a third-party donor whose sperm has been stored in a deep-freeze sperm bank. Before insemination, the sperm samples are prepared in the laboratory. They are assessed for safety, quality, and quantity, and then passed through a filtering system for grading and washing. With a syringe and fine tube, the prepared sperm cells are then introduced directly into the cavity of the uterus, beyond the mouth of the womb and the cervix. They immediately make their own way towards the uterine tube. The objective of IUI is to bring these sperm cells as near as possible to the egg. Nevertheless, only the most mobile sperm cells will actually reach the egg, and only one will penetrate the outer layer of the egg to achieve fertilization. But just as in everyday life, there are many times that fertilization fails and the cycle passes without a pregnancy. All these methods of assisted reproduction offer couples a good chance of bringing a healthy baby into the world. A consultation and thorough examination are necessary for each individual patient for finding the most appropriate treatment with the highest chance of success. Because female fertility decreases quite quickly after the age of 35, infertile couples should not delay seeking appropriate medical advice.
Your surgeon will perform hysteroscopy to view the inside of your uterus. Hysteroscopy can be used to diagnose or correct a problem in your uterus without needing to make an incision in your abdomen. The uterus is a hollow organ in your lower abdomen, where a baby grows during pregnancy. Each month during a woman's childbearing years, the inner layer of her uterus, called the endometrium, builds up with extra blood and tissue to prepare for pregnancy. When pregnancy does not happen, the extra tissue sheds through the vagina during menstruation. A diagnostic hysteroscopy may be done to evaluate causes of abnormal uterine bleeding, investigate possible causes of infertility or repeated miscarriages, or detect benign or non-cancerous growths in your uterus, like fibroids, polyps, scarring, or malformations. An operative hysteroscopy may be done to remove benign growths from your uterus, obtain a tissue sample or biopsy from the lining of your uterus, locate an intrauterine device or IUD, or place small devices in your fallopian tubes as a form of permanent birth control. Before your procedure, you may be given general, regional, or local anesthesia. Your doctor will begin by inserting a speculum to spread open the walls of your vagina. Your doctor will then pull the cervix toward the entry of the vagina. Next, your doctor will use instruments called dilators to open up your cervix. Your doctor will guide a hysteroscope, a thin device equipped with a camera and light, through your vagina and into your uterus. The camera transmits images of your uterus to a screen. Your doctor will inject gas or fluid to expand your uterus, making it easier to locate abnormal tissue in your uterus. In a diagnostic hysteroscopy, your doctor will use the hysteroscope to examine the inside of your uterus. In an operative hysteroscopy, your doctor will insert small tools through the hysteroscope to take a biopsy, remove a growth, such as a polyp, or treat other problems. After the procedure, your doctor may recommend medication for pain relief. You should be able to return to your normal activities within 1 to 2 days after your procedure. You may have mild cramping and some bloody discharge for several days. In vitro fertilization is a process where a woman's eggs are fertilized outside her body, then placed back inside her body to help her get pregnant. A woman's reproductive system includes the vagina, cervix, uterus, fallopian tubes, and ovaries. During the monthly menstrual cycle, one of the ovaries releases an egg in a process called ovulation. After ovulation, the egg enters the fallopian tube. A woman is most likely to become pregnant if she has sex in the days just before, during, or right after ovulation. During this time, a sperm cell from a man's reproductive fluid, called semen, is able to fertilize the egg just inside the fallopian tube. As it travels along the fallopian tube, the fertilized egg, now called an embryo, loses the outer cells that nourished it in the ovary. The embryo passes from the fallopian tube into the uterus. In the uterus, the embryo sheds its protective outer layer, called the zona pellucida, in a process called zona hatching. Zona hatching is necessary for the embryo to implant in the tissue lining the uterus. During implantation, a connection between the woman and the embryo begins to grow. This organ, called the placenta, allows oxygen and nutrients to pass from her to the embryo. In vitro fertilization may be performed if a woman has been having trouble getting pregnant, a condition known as infertility, or it may be done if a woman wants to have a child without a male partner. Before in vitro fertilization, a woman will receive fertility medication that causes more than one egg to grow and mature in the ovaries. A man will provide a semen sample so that the healthiest sperm can be collected for fertilization. If the male partner is completely infertile, also known as sterile, or the woman doesn't have a male partner, a donor may be arranged to provide sperm for this process. In vitro fertilization consists of 3 main procedures: follicle aspiration, fertilization, and embryo transfer. During the first procedure, called follicle aspiration, eggs will be harvested from the ovaries. At the beginning of this procedure, an ultrasound probe will be inserted into the woman's vagina so that her doctor can view her ovaries. Inside the ovaries, the doctor will look for follicles. Each follicle is a fluid-filled sac that contains an egg. Then the doctor will insert a long, thin needle into and through the wall of her vagina and guide it to the ovary. A suction device connected to the needle will collect several eggs from inside their follicles. During the second part of in vitro fertilization, called fertilization, the collected eggs will be taken immediately to a laboratory where they will be fertilized. Fertilization may be performed by insemination, where several sperm are mixed with the healthiest eggs. Or the eggs may be fertilized with sperm injected directly into them during a process called intracytoplasmic sperm injection. The fertilized eggs, also called embryos, will be monitored for 3 to 5 days as they begin to grow. At this time, the lab may create a hole in the zona pellucida surrounding some of the embryos. This process, called assisted hatching, will help these embryos implant in the uterus. Some of the embryos will be used right away for embryo transfer, and the rest will be frozen and stored for future use if necessary. The third part of in vitro fertilization is called embryo transfer, which is done 3 to 5 days after fertilization. During embryo transfer, a tool called a speculum will be inserted into the woman's vagina so that the doctor can see her cervix. A syringe will be loaded with fluid containing 1 or more of the hatched embryos. Then the syringe will be attached to a long, thin tube called a catheter. The doctor will insert the catheter into the vagina, through the cervix, and into the uterus. Once inside the uterus, the doctor will inject the embryos. Then the catheter and speculum will be removed. The woman may continue to lie on her back for about 15 minutes. Endometriosis is a condition where tissue, similar to the lining in your uterus, grows in other areas of your body. If you are a woman, your reproductive system includes the vagina, uterus, fallopian tubes, and ovaries. During a normal menstrual cycle, your ovaries make chemicals called hormones, which signal the lining of your uterus to thicken. The lining, called the endometrium, builds up to prepare to receive a fertilized egg. If the egg isn't fertilized, the uterus sheds the lining through your vagina. This monthly bleeding is called your menstrual period. If you have endometriosis, the lining-type tissue grows outside your uterus for reasons that aren't clear. The misplaced tissue responds to the hormones just like it would if it were inside your uterus. The tissue continues to thicken, then sheds and bleeds with every menstrual cycle. However, the blood and tissue that are shed outside the uterus have no way to leave your body. The trapped endometrial flow can irritate the surrounding area, causing inflammation and pain. Bands of scar tissue, called adhesions, may form, sticking one organ to another or causing your fallopian tubes to close. This can affect your fertility, which is the ability to become pregnant. Endometriosis can form endometriomas, also known as chocolate cysts. These cysts are fluid-filled sacs on your ovaries that can affect fertility. Endometriosis may also result in abnormal bleeding. The most common sites for endometriosis are the ovaries, fallopian tubes, the outside of your uterus, the supporting structures around your uterus, and the lining of your pelvis called the peritoneum. Other sites include your bladder, rectum, and intestines. If you have endometriosis, you may have one or more of these symptoms: chronic, usually worsening central pelvic pain, pain before or during your period, pain during sex felt deep within your pelvis, painful urination during your period, painful bowel movements during your period, abnormal bleeding, diarrhea, constipation, or nausea, and difficulty getting pregnant called infertility. Your doctor may recommend treatment options from the following categories: pain management medications, such as aspirin, acetaminophen, or nonsteroidal anti-inflammatory drugs, also known as NSAIDs, provide relief from pain. Hormone therapy, such as birth control pills, can prevent monthly endometrial buildup and bleeding. You may need a surgical procedure to treat the tissue causing pain or bleeding. Examples of such procedures include removal or destruction of endometrial tissue, removal of adhesions and scar tissue, removal or drainage of cysts, removal or destruction of nerve fibers that transmit pain, removal of your uterus, called a hysterectomy, or removal of your ovaries, called an oophorectomy. Intrauterine insemination, also known as artificial insemination, is a procedure done to help a woman get pregnant. A woman's reproductive system includes the vagina, cervix, uterus, fallopian tubes, and ovaries. During the monthly menstrual cycle, one of her ovaries releases an egg in a process called ovulation. After ovulation, the egg enters the fallopian tube. A woman is most likely to become pregnant if she has sex in the days just before, during, or right after ovulation. During this time, a sperm cell from a man's reproductive fluid, called semen, is able to fertilize her egg as it moves through the fallopian tube. Intrauterine insemination may be performed if a woman is having trouble getting pregnant, a condition known as infertility. Or it may be done if a woman wants to have a child without a male partner. Before intrauterine insemination, a woman may receive fertility medication that causes her to release more than one egg during ovulation. In a process called sperm washing, a man's sperm will be separated from the fluid in his semen. This concentrates the sperm, removes debris, and removes hormones that may cause the uterus to cramp. If the male partner is completely infertile, also known as sterile, or if the woman does not have a male partner, previously washed and frozen donor sperm will be used for the procedure. The doctor will monitor the ovaries for ovulation. Intrauterine insemination must be performed right before or right after a woman ovulates, so that an egg is available for fertilization. During the procedure, the woman will lie on an examination table. A tool called a speculum will be inserted into her vagina so that the doctor can see her cervix. A syringe will be loaded with a small amount of fluid containing the washed sperm. Then the syringe will be attached to a long, thin tube called a catheter. The doctor will insert the catheter into the vagina. The tip of the catheter will be guided through the opening in the cervix and into the uterus. Once the catheter is inside the uterus, the doctor will inject the sperm. Then, the catheter and speculum will be removed. The woman may continue to lie on her back for about 10 minutes.
Fertilization is the epic story of a single sperm facing incredible odds to unite with an egg and form a new human life. It is the story of all of us. During sexual intercourse, about 300 million sperm enter the vagina. Soon afterward, millions of them will either flow out of the vagina or die in its acidic environment. However, many survive because of the protective elements provided in the fluid surrounding them. Next, the sperm must pass through the cervix, an opening into the uterus. Usually, it remains tightly closed, but here the cervix is open for a few days while the woman ovulates. The sperm swim through the cervical mucus, which is thinned to a more watery consistency for easier passage. Once inside the cervix, the sperm continues swimming toward the uterus, though millions will die trying to make it through the mucus. Some sperm remain behind, caught in the folds of the cervix, but they may later continue the journey as a backup to the first group. Inside the uterus, muscular uterine contractions assist the sperm on their journey toward the egg. However, resident cells from the woman's immune system, mistaking the sperm for foreign invaders, destroy thousands more. Next, half the sperm head for the empty fallopian tube, while the other half swim toward the tube containing the unfertilized egg. Now, only a few thousand remain. Inside the fallopian tube, tiny cilia push the egg toward the uterus. To continue, the sperm must surge against this motion to reach the egg. Some sperm get trapped in the cilia and die. During this part of the journey, chemicals in the reproductive tract cause the membranes covering the heads of the sperm to change. As a result, the sperm become hyperactive, swimming harder and faster toward their destination. At long last, the sperm reach the egg. Only a few dozen of the original 300 million sperm remain. The egg is covered with a layer of cells called the corona radiata. The sperm must push through this layer to reach the outer layer of the egg, the zona pellucida. When sperm reach the zona pellucida, they attach to specialized sperm receptors on the surface, which triggers their acrosomes to release digestive enzymes. enabling the sperm to burrow into the layer. Inside the zona pellucida is a narrow, fluid-filled space just outside the egg cell membrane. The first sperm to make contact will fertilize the egg. After a perilous journey and against incredible odds, a single sperm attaches to the egg cell membrane. Within a few minutes, their outer membranes fuse and the egg pulls the sperm inside. This event causes changes in the egg membrane that prevent other sperm from attaching to it. Next, the egg releases chemicals that push other sperm away from the egg and create an impenetrable fertilization membrane. As the reaction spreads outward, the zona pellucida hardens, trapping any sperm unlucky enough to be caught inside. Outside the egg, sperm are no longer able to attach to the zona pellucida. Meanwhile, inside the egg, the tightly packed male genetic material spreads out. A new membrane forms around the genetic material, creating the male pronucleus. Inside, the genetic material reforms into 23 chromosomes. The female genetic material, awakened by the fusion of the sperm with the egg, finishes dividing, resulting in the female pronucleus, which also contains 23 chromosomes. As the male and female pronuclei form, spiderweb-like threads, called microtubules, pull them toward each other. The two sets of chromosomes join together, completing the process of fertilization. At this moment, a unique genetic code arises, instantly determining gender, hair color, eye color, and hundreds of other characteristics. This new single cell, the zygote, is the beginning of a new human being. And now the cilia in the fallopian tube gently sweep the zygote toward the uterus, where he or she will implant in the rich uterine lining, growing and maturing for the next 9 months until ready for birth.
CPD means cephalopelvic disproportion. Cephalus is head and pelvic is birth passage. If there is a disproportion between the diameter of the head and the diameters of the birth passage, normal delivery is not possible. With the onset of delivery pains, the baby descends in the birth passage. This descent occurs continuously throughout the process of labor till delivery. The transverse diameter of the middle of the birth passage is measured as the distance between two bony prominences called ischial spines. If the diameter is smaller than the diameter of the baby's head, then the head gets stuck at this level. As the delivery pains continue, there is pressure on that part of the baby's head which lie between the ischial spines. As a result, localized swelling called a caput develops in this part after some time. If no intervention is done, then the complication of obstructed labor develops. The uterus may rupture, putting the life of both the mother and the baby in danger. In some cases, the uterus gets exhausted. The delivery pains stop and process of labor gets arrested. This condition is called uterine inertia. In either of the situations, a caesarean section is mandatory for the well-being of both the mother and the baby. Caesarean section is indicated in some conditions of breech presentation. One such condition is footling presentation, where the foot of the baby is the presenting part. With the onset of labor pain, the baby descends in the birth passage. As the foot of the baby is not tight-fitting to the cervix, a loop of the umbilical cord can lie by its side. This is called cord presentation. As the cervix dilates, the bag of water may rupture. The amniotic fluid may escape and the umbilical cord prolapses into the vagina along with the presenting part. The cord gets exposed to the external temperature, which is cooler than that inside the womb. In response, the vessels of the cord constrict immediately. This abruptly cuts off blood flow to the baby, putting its life in danger. An immediate caesarean section is necessary to salvage the baby in such a situation. Caesarean section is indicated in some conditions of breech presentation. One such condition is footling presentation, where the foot of the baby is the presenting part. With the onset of labor pain, the baby descends in the birth passage. As the foot of the baby is not tight-fitting to the cervix, a loop of the umbilical cord can lie by its side. This is called cord presentation. As the cervix dilates, the bag of water may rupture. The amniotic fluid may escape and the umbilical cord prolapses into the vagina along with the presenting part. The cord gets exposed to the external temperature, which is cooler than that inside the womb. In response, the vessels of the cord constrict immediately. This abruptly cuts off blood flow to the baby, putting its life in danger. An immediate caesarean section is necessary to salvage the baby in such a situation.